Siwan Thomas-Gibson is a professor at the Imperial College London and a gastroenterologist at St. Mark's Hospital. And Siwan will address the topic of experience and delays in endoscopy and impact on bowel cancer screening. Please, Siwan.
Hi, Michael. I hope you can see and hear me now. I've certainly put up my video.
Yes.
Just wait for the first slide to come. I'll be able to skip over. I've been asked to speed up a little bit, and I'm happy to do that because I can skip over a number of the slides. I'm just waiting for them to come. Let's see. There we go. So this was the date for us. If you look at the bottom, you can see that was actually a social media post on the 5th of March, which is, for those of you who don't know, St. Mark's is based in North London in Harrow. And really that was the first date that we in the hospital knew that COVID was really on our doorstep. And St. Mark's in Northwick Park was one of the hardest and fastest hit hospitals in the UK. Unfortunately, we did hit the news very quickly after that, and we were so rapidly overwhelmed with patients that we didn't have PPE, and you can see our nurses having to resort to wearing their own version of it. That did change, but we had a lot of problems with PPE. So given that we've heard a lot of data and I've got very similar graphs, I'm going to skip over the numbers and perhaps focus a little bit more on the impact to personnel, in particular staff, and what we're doing to support that. This data looks similar to a number of other slides, and it correlates, I think we've sort of heard this, but a staggering reduction in colorectal cancer diagnosis by 72%. And the screening procedures here, you can see they stopped for us, as Steve Halloran said, towards the end of March. Our unit was a couple of weeks before that. And for the eagle-eyed here, you can see comparing 2019 to 2020, there is no April because we did absolutely no bowel cancer screening in April. And although our programs officially restarted in July, we did get going slowly in May and June. And of course, there was a lot of negative press, or at least concern, and there were conflicting messages for our patients and participants of screening, in that there was talk about not saving the NHS as it is for us and not going into hospital unless you really needed to, but at the same time there was concern about missing early diagnosis. So for the staff, I think we had a lot of challenges. There was certainly fear of catching COVID and passing it on to your family. We had colleagues who experienced a lot of guilt, and that was either guilt because they were putting themselves and family at risk because they were redeployed to working, for example, on intensive care, but also those endoscopy staff who were left in endoscopy providing the emergency endoscopy, they felt strangely guilty for not being on the front line, and we had to separate as much as we could those two groups of people. So everybody felt guilty. And there was definitely, in screening and in endoscopy, a loss of team because people were spread all over the hospital, and over 80% of our screening team were redeployed to intensive care, A&E, and on the general wards. I did general medicine for the first time in 15 years, which was scary. We were exhausted. More than half of us as bowel cancer screeners actually caught COVID, and that takes quite a long time to recover from. Some of our colleagues were shielding. There was the uncertainty of practicing in an area that you hadn't practiced in for a long time. We've heard a lot about PPE. What hasn't been mentioned, but was highlighted by one of our British colleagues, is that actually PPE is designed for 6'3" men. It's not designed for the vast majority, certainly of our endoscopy nursing staff. And so there was a lot of problem with getting proper fit testing, and that caused anxiety. As many of you will know, we had new ways of working, new protocols almost on a daily basis. It was very difficult to communicate that and to keep up with what the latest guidance was. And physically communicating with mask and shield in high pressure situations where you're either doing emergencies or the more advanced procedures, because we started with those patients who had recently been diagnosed with big polyps and so on, you know, that was very challenging. And together with that, certainly our colorectal surgeons had been moved off site to cold sites. So we didn't have surgical backup, and that caused a lot of stress. You're all familiar with these pictures, but it makes the point that who is who. You even become less familiar with your own team, and that needed support. This has also slightly been touched on, but Colin Rees and Matt Rutter, who you all know, looked at the factors that prevented our participants from attending for screening. And that was to do with, as I said, the conflicting messages, you know, don't come to hospital, you will catch COVID, you've got to protect the NHS. So they didn't want to come. But actually, we also had the conflict of patients who've either had a fit positive test or had an invitation that then hasn't progressed onto the next stage, or indeed those who are diagnosed with cancer, their anxiety and mental health is much worse. And this has been shown in a number of papers, but there's one example given here. So moving on to recovery, and we are sort of in the recovery process. So we've gone from this, we're actually, you kind of feel a bit naked if you scope like this now, you know, lacking all of the kit. You know, this would seem to be very intimidating for patients. But Alessandro and colleagues, this has already been mentioned, Boo Hussein on behalf of the BSG, have produced quite a lot of data now to say that we can do endoscopy safely. And in more than 6,000 cases here across 18 centres, Boo showed that there were no transmission of COVID to staff or patients. So it is safe, particularly if you screen patients. And so we haven't quite gone back to where we were, but certainly this is me with my colleague, Dr. Suzuki, very recently, and we're getting closer to where we were for COVID negative patients. I'll touch on this. I'm sure many of you are developing similar things. We published this in Endoscopy this month. This is a toolkit that we have developed to try and support our teams who are working under really challenging situations and to try and keep some continuity in the process of endoscopy. And the concept of team huddles and briefings isn't new, of course, but this has been adapted to COVID and looks at the challenges of communication, and some of you may find that useful. So we've supported our staff with what we call wellness clinics. We found they wanted a debrief after being redeployed to intensive care, seeing death very frequently, very much more frequently than they're used to, quite frankly, working in screening. We're preparing for the second wave. We are team rebuilding now. And of course, that stretches beyond endoscopy with all of our colleagues who've also had a challenging time. We've also prepared our patients for the return to screening, and we've actually started to ask them what they feel. And on the green on the right-hand side, Andrew Prentice, I'm grateful for, from our screening centres, provide me with this. So actually, they don't find the PPE intimidating, they find it reassuring. And they reported low post-procedure anxiety. And actually, the vast majority said that they would have been happy in retrospect to come for screening during lockdown. So this is where we are. We're up to about 50%, but that gap still represents a huge additional burden over the next 5 years, estimated an additional 1,500 deaths. So we have to maybe stop the webinar and get back to endoscopy. Thank you very much.